Welcome back to Metabolic Mind. I'm your host, Dr. Brett Scher. Today, I'm joined by Dr. David Ludwig. Now, Dr. Ludwig has an MD and PhD, and he's an endocrinologist, researcher, and professor at Harvard Medical School and Harvard School of Public Health, and he's the co-director of the New Balance Foundation of Obesity Prevention Center at Boston Children's Hospital, and the author of the New York Times bestseller, Always Hungry. And he recently published a paper called Childhood Obesity at the Crossroads of Science and Social Justice, published in JAMA. And it was such an interesting paper and incredibly timely because we're really seeing a lot of enthusiasm from these new weight loss drugs, the GLP-1 agonists, which you may have heard of as Semaglutide, Ozempic, and Wegovy. And they've sort of taken the weight loss world by storm because they seem to be, at least for the short term, more effective than any weight loss drug we've had before with fewer side effects, although clearly not no side effects. But the question becomes, why this reliance on weight loss medications and bariatric surgery, as Dr. Ludwig also mentions in his paper, and why less of a focus on nutrition? And I mean, let's face it, it's harder to completely change your lifestyle than it is just to take a pill. But which is better, right? Which is better for the long term? Which is better for overall health? Or is there some combination of both that should be used, as you'll hear from Dr. Ludwig? It also brings up the issues of cost. I mean, these are very expensive medications, and now they're being promoted for obesity from pediatrics all the way up to adults, which is a huge swath of the population. And you'll hear Dr. Ludwig talk about that as well. But at Metabolic Mind, what we want to focus on is what does this mean for metabolic health? And when you talk about metabolic health, then how does that translate to mental health? So how do we view the drugs versus lifestyle changes differently for metabolic health? So Dr. Ludwig is going to talk a little bit about the mechanisms, which bring up some interesting corollaries with low-carb diets, but yet there's still some differences. So I hope you enjoy this interview with Dr. David Ludwig about this paper he wrote and about this specific topic of weight loss drugs versus lifestyle, and where do we go from here? So Dr. Ludwig, thanks for joining me to discuss this paper that you recently published in JAMA about childhood obesity. And well, I'll just read the title: Childhood Obesity at the Crossroads of Science and Social Justice. So first, take a step back. Why'd you write this paper? What motivated you to do this?
Well, great to talk to you again, Brett. And so there's a lot of excitement about these new incretin-based weight loss drugs. These are drugs that are designed to mimic the effects of gut hormones. One in particular is GLP-1. Now, GLP-1 seems to be a satiety hormone, and we can talk about its actions. Now, these drugs act in the body and in the brain to produce satiety, and based on their isolated actions, it seems that they raise insulin, and that kind of creates some kind of confusion, because if insulin is a hormone that is driving weight gain, how could these drugs produce weight loss while also raising insulin? So we wanted to look at how these mechanisms in test tubes may not really reflect their actions in a real life situation among people who are eating their normal diets. We also wanted to put this into a broader perspective. These drugs cost about $1,400 a month, more than $1,000 a month. So to put everybody with obesity, let alone just the adolescents, but everybody with obesity on these drugs would be extremely expensive, $1 trillion across society. And that's money that would come from taxpayers, it would come from the government, we would pay for it in higher insurance costs. So we wanted to take a big picture and ask, what are these drugs doing? What is their proper role in obesity treatment? And how might this actually fit in to what we know about diet? Rather than diet or drugs, could we create a bigger picture of diet and drugs and find their proper place?
Yeah, I think that's a great introduction. And I want to get into the mechanisms because I think they're really interesting. But first, I want to start with this concept of, you mentioned about how there are guidelines that came out recently about treating childhood obesity, and it focuses on bariatric surgery and these GLP-1 agonist drugs and has very little attention to diet. And a lot of the skeptics, myself included, will say, well, hang on a second. Obesity didn't occur because of a drug deficiency or didn't occur because of, specifically abnormal anatomy. So why then is the treatment the drug or the anatomy rather than kind of undoing what may have caused it in the first place? So give us your perspective of why nutrition has sort of been downplayed, I guess you could say, as a treatment for childhood obesity.
Well, as you indicate, obesity isn't caused by an inborn problem with the digestive tract that requires surgery or inherited hormone problems for most of us that require drugs. So in principle, we must focus on diet, lifestyle, and the other factors in the environment that are causing the epidemic. The issue is that for the guidelines that the American Academy of Pediatrics just put out, these are evidence-based guidelines, and they have to be based on scientific evidence. And in that regard, the data for drugs and surgery are much better than for diet. Now, this doesn't mean that diet doesn't work. It just means that drug companies with their billions of dollars for phase 3 clinical trials, or surgical centers that can get lots of money for randomized controlled surgical procedures that cost $40,000 or $50,000 a pop, that they can generate much more compelling data. The total NIH expenditure for childhood obesity research is just $250 million a year. $250 million a year. You can barely do one phase 3 clinical drug trial for that. So one answer is going to be to better invest in the kind of nutrition research that's going to generate high quality data. We can't just keep doing these small, low quality, low intensity diet trials where people don't really change their behavior very much, and then fool ourselves into thinking that we're learning something basic about diet. We need to approach diet as we would drugs. I mean, in fact, if anything, it should be better funded because changing behavior is more complicated than taking a pill.
Yeah, I think that's a great point. I mean, do you take the pill or you don't take the pill? You have the surgery or you don't have the surgery. With nutrition, it's much more complex than just that. And that's reflected in the low quality of a lot of the dietary trials. Now, you're someone who's run a number of different dietary investigations and studies, so you know the challenges. So when someone makes a blanket statement like, just dietary research is just terrible to begin with, you're part of that. Would you agree with that? That most of it is pretty low quality and doesn't really help us?
If you approached a drug company scientific advisory board with the typical diet trial that's conducted, they would laugh you out of the room. They would know that in advance, you're not going to learn anything significant. If you did a drug trial and people didn't take the drug, or they had some side effects and they stopped taking it, they didn't know where to buy it or whatever, and the people in the drug group didn't show a benefit, would you blame the drug? No, you'd say that you'd blame the trial, and you'd say we need better research. Somehow that logic is routinely applied to nutrition research. So we need to conduct, there's never been a single high quality, multi-center, low carbohydrate diet trial comparable to a phase 3 drug trial, despite on low carbohydrate diets, despite the fact that this approach shows a lot of promise for diabetes and weight control. So we know that the low carb diets, contrary to what was billed in the low fat era, these approaches are more, not less effective than a low fat diet, just based on the calorie in, calorie out model. But we can't know their true potential until we've done a high quality, high intensity trial that really supports people to change their behavior. We know behavior change is difficult, but it can be done. You first of all need to intervene in the home. Many people don't know how to cook, or they don't have the basic appliances and cooking utensils to prepare a diet. So, enter the home, help people make their foods, give them hands-on cooking classes, group support. Some people might need behavioral counseling. Let's do a trial that can really motivate people rather than saying simply because people don't follow these diets for the long term in poor quality studies that the diets will never work. That's nonsense.
Yeah, well said. So the other part to bring up, though, about surgery, about medications, especially when you're talking about adolescents, but also applies to adults, is what is the long-term ramifications of this? Like if you're, have bariatric surgery and then need to live another 50 years, what happens to your nutrient absorption and your protein absorption? And as we've seen with these medications, as soon as people go off the medications, the weight comes back on. That's, there's a published study showing that. So do you have concerns about the long-term implications of treating a pediatric population with surgery or medications and not addressing the diet?
Well, there's certainly people in the world of nutrition, public health, who are allergic to using drugs for some of those reasons. And I'd like to take a middle ground here, although I guess what's middle ground is relative to your perspective. I think there is a role for these drugs, and rarely bariatric surgery. For somebody with severe obesity, suffering uncontrolled diabetes, sleep apnea, fatty liver, maybe bariatric surgery will be life savings. But what does it say about society if we can't limit junk food advertising to children? We can't create an environment where they exercise their bodies, they have access to nutrition foods, and instead want to funnel them to drugs and surgery. That's a pretty sad comment. So we need to put drugs into a proper perspective. These new incretin-based drugs are they launch a new era. They're much more effective with fewer side effects, and they have a role. And as you said, we don't know what the long-term consequences of starting these drugs in adolescence will be. They modulate fundamental metabolic pathways in the body and in the brain. So we want to use them with some caution and humility. And that's where the question, could there be synergy with diet, comes up. Now, as we began earlier to discuss, these drugs are simplistically viewed as raising insulin levels based on their actions in the laboratory. But the GLP-1 agonist drugs, Wegovy, Ozempic, these new drugs that are getting all the attention, they actually also slow down gastric emptying. They cause the food that we eat in a meal to be released from the stomach and thus digested more slowly. And that's a big effect at first, and that effect wears off a little bit, but it persists permanently as best we can tell. And as a consequence, insulin secretion decreases because the effects on the stomach are more important, or dominate the effects on the beta cells. And in that regard, it looks like a low-carb diet. What does a low-carb diet do? Well, if you either have slower digesting carbs, so low glycemic index, or less carbs and more protein and fat, those foods exit the stomach more slowly. They take longer to digest in the small intestine. They reach further down the digestive tract. They produce a more gentle rise of blood sugar and insulin. And because they get further down the digestive tract, they release more GLP-1, the very hormone that's the basis of these new exciting drugs. So interestingly, people on these drugs note that they can't eat a high-fat diet because they get just intensely full, too full. Well, rather than not eat a high-fat diet and keep taking the drugs at the usual dose, let's eat a low-carb, high-fat diet and enable it to decrease the drug dosage. That's going to save money, maybe decrease side effects, and produce synergy.
Yeah, I think that's a great perspective. And anytime you look up the mechanism of action, it says that it increases glucose-dependent insulin secretion, which, as you're saying, makes everybody think, so it raises insulin. But I like how you laid out the real world, the real body effects, which actually then cause it to decrease insulin. And that's sort of the synergy or the parallel with low-carb diets and how that can contribute.
Yeah, this effect
to weight
is
loss.
very robust and very clear, except in severe diabetes, when the beta cells are no longer even responding to blood sugar, the incretins will raise insulin. But that's a very extreme situation. In earlier stages of diabetes, and for people using it specifically for obesity, the effects are quite clear. That with that first drug dose, gastric emptying is reduced, insulin and blood sugar are decreased. You get a range of other beneficial effects on hormones that look like a low-carb diet. Ghrelin goes down with these drugs and with a low-carb diet. Leptin also goes down, which suggests improved leptin sensitivity, which is a metabolically beneficial state. Adiponectin goes up. So why not take advantage of the potential synergy? Ultimately, many people will benefit from a low-carb diet and won't need the drugs. But if you do, it's not necessarily one or the other, as is so often the case in these clinical trials. How about both? Let's use both targeting metabolic benefits to obtain synergy.
I like how you said targeting metabolic benefits, because so far the discussion really is around weight loss. But at Metabolic Mind, we're focused more on metabolic health and how that relates to mental health. So it leads to the question, does weight loss from a GLP-1 agonist provide the same metabolic benefits that weight loss or just adhering to a low carbohydrate ketogenic diet would do? I mean, we don't have direct comparisons, so I understand there's a lot of sort of theory and hypothesis, but I'm curious what you think. Yeah. I mean, when it comes to metabolic health, not just weight loss, what do you see?
Well, okay, so we talked about some potentially large areas of overlap between a low carb diet and these new incretin agonist drugs. There's some things that the drugs do that a low carb diet doesn't do. For one, the long-acting drugs like Ozempic and Wegovy penetrate, so Semaglutide and liraglutide and these long-acting agonists reach levels in the body and last long enough so that they can penetrate the brain and activate GLP-1 receptors in the central nervous system. Now, a lot of people say that that's evidence of direct effects on hunger and satiety, although these pathways also modulate metabolism. It's not, you can't sometimes say, distinguish cells that affect hunger from the cells that also affect metabolism. Oftentimes these pathways do both. Clearly the food that you eat in a low carb diet doesn't enter the brain in the same way. But the other side of it is that a low carb diet could have effects that these drugs don't have, such as by increasing ketones substantially. And ketones do cross the blood-brain barrier, nourish the brain. They have metabolic benefits. They are anti-inflammatory, as you well know. And they're generally good for a variety of mood and possibly neuropsychiatric diseases. So we can cover a wide range and meet in the middle between the drugs and the diet.
Yeah, so when it comes to mental health, certainly from a mechanistic standpoint, having the brain run on ketones seems like a very beneficial thing, which the GLP-1 agonists won't do. But I see how you're talking about using them together.
So maybe
for sure.
that we can use the drugs. This is not an argument. Again, we're pushing back against the. And my co-author Jens Holst is commonly credited as the person who discovered GLP-1 as a hormone. And so he's certainly enthusiastic about the use of these new drugs for weight loss. But he joined me in the call that this can't be the frontline treatment, especially for childhood obesity. So one approach might be to, we use all sorts of drugs that we might not have needed to take in a more natural environment, when we're hunter-gatherers and such. So maybe we take the drug to help jumpstart weight loss, use the diet to enhance the effects and get synergy, and then that diet is there in place so that when you decrease the drug dose or come off it, you've got something that's going to prevent the weight regain from occurring.
Yeah, I think that's a great way to say it. That it's almost like a bridge to help with the long-term success, which is going to come from lifestyle and nutrition.
So we don't have to be absolutist. I don't think we have to get into camps of drugs and you don't need to worry about diet, or diet is everything. And, anybody who's using the drugs is demonstrating a weakness of character. I think there's a middle ground, although which direction I lean.
Well, yeah, and in long-term metabolic health is the focus. And that's what I would say is the non-negotiable focus. And how you get there are different ways to get there. But one part of metabolic health can also be body composition. So that's one concern that's come up with GLP-1s is the loss of muscle mass. Now, with any extreme, or not even extreme, but significant weight loss, there's bound to be some loss of muscle mass. But the key is like putting it in perspective of muscle mass loss from GLP-1s versus, lifestyle interventions. And it seems to be more prevalent with GLP-1s, which brings up the question, are we going to create a society of, TOFIs, thin on the outside, fat on the inside, low muscle mass, people using these medications? Do you have concerns about that?
That is a concern that has been raised, although I don't think the data are sufficient to know whether these drugs produce a greater loss of lean mass than would be expected from their very rapid rate of weight loss that they produce. So in other words, if you were successful with a rapid, very restrictive, low-calorie diet, would you lose less lean mass than you would on the drugs? And I don't think that that's been shown. I also don't see evidence for substantial increases in metabolic syndrome, insulin resistance. I think the opposite. And that may in fact be in part due to the shared mechanisms of lowering insulin, functionally converting a fast digesting carbohydrate meal into a slow digesting carbohydrate meal. These drugs also seem to have anti-inflammatory effects. But again, so I don't know that we're creating a generation of TOFI, but it's something that needs more research. And it's always wise to be cautious about use of these drugs in adolescence during the development of the brain and the body, or for many years at a time, when we just inherently don't have that long-term data to guarantee that we're not going to see unexpected adverse effects.
Yeah. So interesting to compare the rapid weight loss from the drug to rapid weight loss from, liquid replacement weight loss. But how about comparing it to sort of the slower weight loss that comes with, comprehensive lifestyle change? That's where you're less likely to see that decrease in lean body mass. And then what's the long-term consequence if you do have that loss of lean body mass? What's the long-term consequence of that along with the drug? So all unanswered questions, which, we can certainly hypothesize about, but certainly interesting to think about. I think this was a great overview of the paper that you wrote, and I applaud you for writing it and bringing up all the issues like you talked about with cost and longevity and the focus on drugs instead of lifestyle. Any last words or things to sum up from you?
The paper is, all of that was in 2 printed pages. And
yeah, I don't know how you did that in 2 pages.
Very sparing of words. So it's open access for the next month. So I encourage your viewers to just click on the link that I think will be in your lecture notes and download the paper and see what they think. We'll, there's a lot of questions that hopefully will be answered, importantly with better government investment in nutrition research over the next few years.
Yeah, if anything else, it's certainly a call for better nutrition research, which is something we definitely need. Well, thank you again. Thanks for taking the time to share with us today.